Okay, I'm back again. But this time we're going to be talking about sex. We're going to be talking about sex on the panel. We've got some incredible experts to share with you. So let me come on up here. Come on over here while I introduce you. Stephanie Prendergast is a pelvic floor physical therapist and co-founder of the Pelvic Health and Rehab Center with 11 locations, including Pasadena, where she sees patients. She was the first physical therapist to serve as president of the International Pelvic Pain Society and is co-author of the Pelvic Pain Explained. Welcome. Thank you. Dr. Sameena Rahman is a board-certified OBGYN and founder of Center for Gynecology and Cosmetics. She is an assistant professor at Northwestern's Medical School and on the board for International Society for the Study of Women's Sexual Health. She also hosts a podcast called Gyno Girl Presents Sex, Drugs, and Hormones. Welcome. Somebody really liked that. Dr. Lauren Streicher is a clinical professor of OBGYN at Northwestern's Medical School. She is the founding medical director of its Center for the Sexual Medicine and Menopause, also author of 4 best-selling books, including Slip, Sliding Away, Turn Back the Clock in Your Vagina, and is the host of Dr. Streicher's Inside Information podcast. Good to see all of you. All right, we've been waiting for this one now as well because we had some great panels today. I feel like I've learned so much information and filled out that little notebook that they gave us. Dr. Streicher, I want to start with you because we hear GSM a lot thrown around. So can we just define it, what it is, and just kind of break it down for us?
Absolutely, and I'm going to stand up because I'm going to do a little show and tell here because we're going to be talking anatomy. So genital urinary syndrome of menopause are the physical changes and symptoms that occur in our genitals and in our urinary tract, genitourinary. But basically it's what happens to our vulva, our vagina, and our bladder when our estrogen tank is on empty. And it's going to happen to 70% of you. So that's what GSM is.
I'm glad I asked. All right.
Because we get really tired of saying genitourinary syndrome of menopause. Yeah. But let's talk symptoms for a minute. Now, the panel's really going to be addressing all these symptoms. But what I want you to know is a lot of these symptoms, and we are talking not just sexual symptoms, but also just vulvar vaginal symptoms that are not sexual, and urinary symptoms. So many women think that these symptoms are just part of aging, because maybe their doctor told them that. But all of these symptoms are a direct result of a lack of estrogen. So what I'm going to do next is I'm going to walk you through some anatomy, because guys have the obvious advantage of being able to inspect their genitals with absolutely no effort on their part. And they do it all the time. For women, things are not only a little more hidden and a little more mysterious, but quite frankly are very often taboo from a young age. So I'm going to walk you through all this, and we're going to start with what's going on in the pelvis. And this is a woman who has been conveniently cut open in half. And right here we have the front and the back. And let's start with the uterus, because that's the center of action right there. And then, of course, the uterus is attached to the vagina. In front of the uterus is the bladder, where urine collects. And when you need to go to the bathroom, hopefully not before, the urine will come out through the urethra. And then, of course, as we go backwards, that's where the bowels are, the rectum, and stool comes out of the anus. And then a very important part that also is not talked about enough, but Stephanie Prendergast is going to be talking about it a lot, is the pelvic floor, which is a group of muscles that supports all of this. And when they work right in a coordinated fashion, helps your bowel function, your bladder function, and your sexual function. So we're going to be spending some time talking about that as well. So under the theme of things that you cannot see, we're next going to be talking about the vagina. Let's talk vagina. So this is actually one vagina which we've divided in half to show you the difference. And keep in mind that unless you own a speculum, you cannot see in your vagina. All of us here, we get to look in the vagina, and I will tell you, it is not subtle, these differences. These are physical changes. So when any doctor, any clinician puts a speculum in, they are going to know, is this a vagina that has estrogen or is this a vagina that doesn't have estrogen? So right over here we have the 30-year-old vagina, and the 30-year-old vagina has some nice pink color, and it's got lots of lubrication, and there's all kinds of these little ridgy folds here, these accordion-like folds that allow the vagina to expand, to accommodate a penis, a toy, whatever, a baby if that's the part of your life that you're in. But then, post-menopause, these are not subtle changes. These are very dramatic changes. And it should only happen to your hips, but here is where things get thin. Thin and dry, really dry. And you lose those all-important little accordion-like folds, which means that you lose the elasticity, which is why things are not stretchy. You lose that elasticity. So let's move on to something that you actually can see. And this is the vulva. Now, 90% of the time when a patient comes in and says to us, oh, there's something wrong with my vagina, it itches, or I have a rash, or it looks funny, they're not talking about their vagina. They're talking about their vulva. No one can see their vagina. And this is something, again, we talk about taboo topics. How many mothers teach their daughters, wash your vulva, honey? Wash your vulva. You know, we don't even know those words. So the language is very important, which is why we're taking the time to go through this. So when we look at the vulva, and this is obviously a cartoon, it's not really what vulvas look like. There's wide variation, many, many different lengths of labia and sizes and shapes, and it's all normal. But when we start, let's start at the top with the clitoris, which of course is the source of most sexual pleasure. And then as we move down, we have the urethral opening, the labia minora, and the anus is down here, vaginal opening. But this is a part that we're going to be talking about a lot. And this is called the vestibule. And for many women, as we start to talk about sexual pain, the vestibule is the source of the pain. Women think, well, I'm using estrogen, I'm using a lubricant. Why is it still hurt? Well, because more often than not, you're treating the vagina. And it doesn't matter how nice the room is if you can't get through the door. The vestibule is the door. So we're going to be spending some time talking about that. So there you have it. Oh, one more thing. This is the important part. Why does all this happen? Well, it's because there are estrogen receptors every place. Everybody thinks it's just in the genitals, it's just in the uterus, it's just in the vagina. But in fact, and you've heard all morning about estrogen receptors in your brain, in your joints, in your skin. They are throughout the body, including the urinary tract. Lots of estrogen receptors there, including pelvic floor muscles, including the vulva, all of these areas, and yes, the bowel. But there are estrogen receptors and testosterone receptors throughout this entire area. So that's why we see these changes. That's why you have these symptoms. You are not imagining. We've talked a lot this morning about people are just kind of taught like, oh, this is on your head. This isn't real. This is real. And that's why when you go to your doctor or your clinician, we like to use a mirror because it's very validating for women to see these physical changes and know that it's not just something that they're thinking. It's real. So now we're going to get real and turn it over to the panel.
All right, now that we understand, we have a lot more to talk about. Dr. Rahman, let's start with you. Let's talk about urinary symptoms, because that is something we touched on a little bit earlier. I heard some questions about it. How common are these during this time?
They're incredibly common, actually. I think at least 10% of women, 1 in 10 will have at least some urinary symptoms beyond menopause. Actually, some of the symptoms are even more common, like close to 80% of women get up in the middle of the night. That's called nocturia. There's pain with urination. So like that vulvar vestibule that we were discussing, has the estrogen receptors, it has testosterone receptors, but the top part of that is right under the urethra. So people can sometimes have burning and pain when they urinate. They can get the frequency, the urgency, the I gotta go, and then they have the dribbling on the way. That's the urge incontinence symptoms. And then of course, just like recurrent infections, right? Like this is the big problem, right? Once women, I think it's 50% of women have recurrent urinary tract infections beyond menopause. And so it's a big problem. If you look at actually statistically, the statistic is 25% of geriatric hospitalizations are due to urinary tract infections. And so that starts out, okay, a UTI is what it starts out with, but then it can go to your kidneys, right? That's pyelonephritis. Then it can go to your bloodstream, and that's urosepsis. And urosepsis can kill people, right? Because I think it's 6% of patients, women with urosepsis, 6% of those patients that were admitted with UTIs can actually die from them. So I always say that the treatment we use for genitourinary syndrome menopause is life-saving because of that, because if you're getting up in the middle of the night for nocturia, you might fall down, and then what happens when you break your hip in the, when you're 80 years old, you break your hip because of your osteoporosis and osteopenia, whatever. There's a mortality rate of, what's like 30% in the first year after you break your hip. So all of these contribute, and so the stuff that we're going to talk about treatment-wise, can be very life-saving.
Well, why does it increase? Why do urinary problems increase after menopause?
Goes back to the hormones, right? We have estrogen in all throughout the genitourinary system. We have it in the trigone of the bladder. We have it in that vestibule. We have it in the vagina. And what happens when the vaginal microbiome changes with the loss of estrogen? You go from an acidic pH to a basic pH. So if we have the normal, healthy lactobacillus that's keeping our vagina nice and acidic, that changes when you don't have estrogen. We talked about the physiologic changes. That vaginal microbiome is so important. And so you get this growth of these bacteria that, are known to cause, infections in the vagina, but also in the bladder. And so when that tissue changes, when that thinness becomes more prominent, when the urethra changes, and when you lose that support, right? The estrogen is so important for your collagen production and the connectivity in your connective tissue. So when you have like less elasticity even around the urethra and the muscles change around there, then you get those bacteria that can jump right into the urethra and cause all these UTIs. But the same happens with the urethra when it comes to like the burning. We talked about the vulvar vestibule and how it changes. All of this is related to hormone deficiency. In fact, just as a side note, most of us know these periods of vulnerability that we talked about. Postpartum is another period where you have hormone deficiency, and people have this genitourinary syndrome of hormone deficiency. And it's the same thing that happens to women, a subset of women on chronic birth control use, because it becomes like a syndrome of hormone deficiency. So, the hormones are very important. We have testosterone receptors in the vestibule as well as the vagina. So again, we're losing 50% of that at the time of menopause. So these are all very important to keep the genitourinary system healthy.
Yeah, let's go back and talk about the genital and sexual symptoms of GSM.
So when we talk about sexual symptoms, the way that I like to divide it is I always start with the number one most common sexual symptom that women have, and that's loss of libido. You say, well, what does loss of libido has to do with genital urinary syndrome of menopause? Loss of libido is a downstream effect of sex that hurts like hell. Let's just start like that. When someone comes in and says, I have no libido, I don't think about sex, I don't want sex, I have no desire for sex, and my first question is, well, the last time you had intercourse, how'd it go? Well, it hurt. It really, really hurt. Okay, well, your vagina's not stupid, and your vagina's going to tell your brain, don't go there anymore. So it is all part of it. But the reason that there is so much pain with intercourse is because of the physical changes that I was speaking about earlier. The tissue becomes so thin, it becomes so dry. There is absolutely no lubrication there. So what happens? Sandpaper sex, stabbing pain. And then what happens, which we're going to get to, is the muscles tighten up. But I'm not going to go there because that's Stephanie's job. But the point is that these are absolute physical changes that are causing this to occur. But then we get to orgasm. Just raise your hand if last time you went to your doctor, if he or she asked you if you were able to have an orgasm. And it can't be my patients. None of my patients can. Exactly. We had one hand out of 200 plus women. When a guy goes to his doctor, how often do you think someone asks him about if he's able to have an erection? So we have this big problem, but again, the theme that we keep talking about is they don't ask, because if they ask you, are you able to have an orgasm, you say, I'm so glad you asked. I can't have one, and the doctor has nothing to say, but I'm so sorry. They don't know how to help you, so they don't ask. But having difficulty with orgasm occurs in 50%, 50% of women around the time of perimenopause and menopause, and it only gets worse as time goes on. Why? Well, one of the consequences of genital urinary syndrome and menopause, other than the dryness, is you actually get a change in the blood supply. You need decent blood supply for your clitoris to wake up and actually respond to stimulation. You need blood supply for those nerve endings to be healthy and respond. So for that reason, many women are not able to have an orgasm, and we do have fixes for this. We'll get to that. I don't want you to all sit there and go, great, it's over, it's all over. It is not all over. We're going to get to the fixes. But then we look at the non-sexual symptoms, and for a lot of women, sex is just not part of their life, and that's okay, but there are non-sexual symptoms of genital urinary syndrome and menopause. These women who just have this vulvar itching, burning, discomfort. They find that they really don't want to wear jeans or anything because there's always what we kind of call this genital awareness that's really, really unpleasant. And then, of course, as Sameena already talked about, the recurrent urinary fluxes, the gotta-go feeling, all of that. So it's not just about sex.
Okay, thank you. Stephanie, you're up. Ready? All right, so, there, a lot of us know little to nothing about pelvic floor. So what is it, and what do we need to understand about it a little bit better?
Right, thank you, and there is hope coming. But all the symptoms that you just saw that are also the genitourinary syndromes of menopause, minus the libido issue, are also symptoms of premenopausal and menopausal pelvic floor dysfunction in women. So these muscles run from the pubic bone to the tailbone. They support our organs, they're part of our core. They contracted repeatedly and fast for an orgasm, so there is a way to exercise them that is pleasurable for those of us who hate exercise. And they basically keep us continent during the day under normal circumstances, and they are under autonomic control, which is kind of like our breath, which means that they are being controlled by something out of our control, but we have the ability to override that. For example, when we decide to urinate in an appropriate place, or trying to hold our urination if it's not appropriate. So when these muscles become dysfunctional, it's a big, hot mess. I mean, when I just described all the functions that they have, if this was my company, I would do a reorganization because they're too responsible for too many things. Urinary, bowel, sexual function, our pleasure, our ability to wear clothes, our ability not to have hip and back pain. So when people advance in age, they can become tight, or the muscles can become weak. In most of our menopausal women, I consider my patients like a Prius. They can be a little bit of both. And what's important to know is that over time, our muscles also are hormonally sensitive. We start losing testosterone at 35. Just like every other ache and pain can start, the pelvic floor is no different, except for it's a little special because of all these sensitive structures that Dr. Rahman and Dr. Streicher just talked about. When they start to become painful, they are going to cause the muscles to involuntarily contract. This can cause pain, but it can also cause a functional weakness because they can't contract and relax the way that they should to support our bodies. So then we start leaking, then we start having hip and back pain. A huge study that came out recently showed that 95% of women who had low back or hip pain also had pelvic floor dysfunction. But pelvic floor physical therapists are different than orthopedic physical therapists. These things should not have been separated. But if you go to an orthopedic physical therapist for your back, chances are they're going to give you exercises that are bad for your pelvic floor, and all of these symptoms are going to get worse, and it's not going to feel good. So we're working to rectify that.
We're going into treatments, I promise. And there's 6 different things I'm going to cover. We'll make sure we get through them, and so we can also have Q&A. So we know treatments are important. Just quickly, why are they so important?
Well, the reason they're so important is unlike the hot flashes, which might take 10 years or more, they will eventually go away. The brain fog will go away. The insomnia hopefully will go away. But guess what? If you do not treat the vulvar, vaginal, and urinary tract symptoms, not only are they not go away, it's going to get a whole lot worse. So this is a lifelong issue, but the also good news is you've also heard throughout the morning about how the best time to start hormone therapy is, in your 50s, 60, and all that. That's not the case. With the treatments that we're going to talk about, I have women who've started these treatments when they are 90, and are 100% cured. So it does need to be treated, and it's lifelong. You never stop.
Okay, so let's jump into the first one. Vaginal estrogen, what is it and what can it treat?
Well,
Either one of you.
I can start a little bit with vaginal estrogen because, so vaginal estrogen, you've already heard about it. This is a local application of estrogen, which has minimal to no absorption, which means, as you know, any woman can use it and you can use it lifelong. It does not accumulate over time. But it's not just a cream. We have rings, we have tablets, we have suppositories. There's an oral pill that I think we'll talk about in a little bit. There's a lot of different options. But the one thing I want to mention before I turn it over to Dr. Rahman, is that so many women are told, take this cream, put it in your vagina, end of story. No. You want to slather it everywhere. And I'm not even talking about your face. That's a whole different story that we're not going to get to today. But the point is, yes, you start inside your vagina, and then you put a whole bunch more on your vestibule, and then you go north. Put it on your urethra. Your clitoris loves vaginal estrogen. It's going to increase the blood flow. It's going to make it more sensitive. It's going to help those nerve endings wake up. So many people are afraid of it that they're like, oh, I'm going to take this teeny little dot, and I'm probably going to get dementia, and I'm probably going to have a clot, and I'm probably going to get breast cancer because that's what the product label says. Don't get us started on that. When in fact, that is just not the case. Slather it on.
Well, let's talk about this. I'll have you guys bounce back and forth because you hit some of the myths of it that we think, we hear, are repeated over and over. Myth number one, vaginal estrogen increases the risk of breast cancer.
Not only does it not increase it, but there's one very good study that shows it actually decreases a little bit. But it does not increase it. And I think everyone on this panel would agree that I cannot think of one medical situation in which someone cannot safely use estrogen. And if you've been told vaginal estrogen, and if you've been told otherwise, not true. We don't have the data to support it.
Right, and you just have to ignore that black box warning, which is a whole other story. But
we're all trying to get rid of it. Just we'll put it that way.
It's been a long journey, but the vaginal estrogen is so critical. Like I said, it is life-saving. We just talked about how UTIs kill women in the beyond midlife, and when you fall from getting up in the middle of the night, it's very life-saving. There's all these different forms we talked about, and vaginal. We're going to talk about another thing is vaginal DHEA, which is called prosterone or Intrarosa is the name brand, but trade name. But it is DHEA. It's intravaginal suppository that you use. It converts into estrogen and testosterone in the vagina. And so it's really critical because, like I said, we have estrogen receptors in the vagina and the vestibule, but we also have testosterone receptors. So there's a handful of people that will use all sorts of vaginal estrogen all day, and they do not get symptom relief when it comes to having sex. They're still having that introital pain with sex, and that's because they're not getting any testosterone to their vestibule, to that opening, which is really androgen dependent. And so the good thing about DHEA, the studies have shown that when you're using it every night, it'll trickle down into your vestibule and you'll get that. Alternatively, some people we've had to compound estrogen and testosterone as a gel form that you add to the opening, with certain pharmacies that are trusted. So I think that that's also an important topic to realize because sometimes people don't get the symptom relief they need from vaginal estrogen, from pelvic floor therapy, and the DHEA or the estrogen testosterone gels.
We're talking about so many different types. So how do you decide, and let's just do this briefly so we can hit the other five, what to prescribe and at what dose?
I always say whatever the patient's actually going to use is what we have to try to take. And what the insurance covers, right? Like that's big. Those are big topics. Like I love the estrogen ring. The S-ring is what it's called, but it's every 3 months, and it's great for my elderly patients who can't, they don't want to use something down there all the time, and they don't want to shove up anything up there. But the problem is insurance doesn't readily cover it. It's a big problem. I think the cheapest is probably Uvafem or the estrogen tab, actually, that you put into the vagina every Vagifem, Uvafem, and also estradiol cream, estrase cream is also very cheap. But so it really just depends on what the patient's preference is. Like some patients are like, I do not want to do anything down. I'm not sticking anything down there, okay? I'm having urine symptoms only. I'm not doing anything. So maybe they're the ones that need an oral agent that we haven't talked about yet, but it is an oral agent that is used for the genital urinary syndrome of menopause, Osphena.
But I do want to add one thing. First of all, a lot of women are taking systemic estrogen, and it does not necessarily mean that they are going to get the vulvar vaginal support that they need. About 25% of the time that someone is using a transdermal estrogen or an oral estrogen to help with their hot flashes, etc., they are not going to get relief. So they can need also to use a local vaginal estrogen. And no, it is not too much estrogen, despite what your pharmacist might tell you when you go to pick it up. It's perfectly fine. The other thing I want to add is, yes, it's personal preference, it's insurance. But a lot of women will choose to use something like the little tablet, the little pill that you put in your vagina, because it's neat, it's clean, it's convenient, it's great. But that's not necessarily going to help your vestibule. So part of it is where do you have the most problem? And we also very often will prescribe dual treatment, meaning someone says, I don't want to use estrogen cream because it's like plopping out on my shoe every time I go for a run. It's really messy. You can put a tablet or a ring in your vagina and then also use the cream for your clitoris, your urethra, and the vestibule. Sometimes you need to get creative.
Absolutely.
All right, let's go to testosterone because we did have a lot of questions about that earlier this morning. Explain what happens to a woman's testosterone after menopause.
So first of all, let's just start by saying testosterone is not a male hormone. It is a human hormone, and it is just as important in women and in men. Please spread the word. So when you make testosterone, you make it from one of two places. You make it in your ovaries, and thank God there's a backup for women who lose their ovaries. We also make it in your adrenal glands. Actually, most of it comes from your adrenal glands. Now, there's this idea that when you go through menopause and there's this precipitous drop in estrogen, the same happens with testosterone. That's actually not the case. You can start to lose your testosterone prior to menopause, and then it gradually continues to go down. Even when you're no longer making estrogen, you are still making some testosterone. It actually comes from a different part of the ovary, so there's the good news. But testosterone is extremely important, not just in things like libido, and we're talking about testosterone receptors in the vagina and the vulva, but we're not getting into a whole discussion about it today, but things in terms of like your muscles, your joints. There's so many other things that testosterone does for both men and women.
All right, Dr. Rahman, what forms does it come in and what do you recommend?
Testosterone. So we have no FDA, the government hasn't allowed us to have an FDA approved version of any kind of female testosterone. There's one government in the world that actually has approved testosterone for women. Anyone want to guess? Australia, okay. You've heard this talk before. Okay, so yeah, Australia. So it's called andropheme. That's what they use over there, and you can order it online. But I use Testim usually, like a male version of testosterone at 1%, and you have to titrate it. It's like alchemy. Like we're trying to figure out how to tell patients to use testosterone. So usually, like when a man gets Testim in these tubes, it's 30 tubes that he uses. For 30 days. But that one tube for women is supposed to last us 10 days. So if you get a 30-day supply, which if your pharmacy allows it, I mean, now pharmacies I think have gotten used to like for me to call it in, but for the first year of doing this, it was like fighting them to give patients testosterone, or you'd get these prior authorizations, and it was crazy. But testosterone, it's the one tube lasts 10 days for women. So the one tube has about 5 cc's in it. So you use about half a cc a day, or like I always say, like the size of a plain M&M, or a pea-size amount. I mean, I know it's like strange to tell patients, but you have to kind of put it on, rub it on the back of your thigh, and we kind of see how your symptoms improve. Most societies really recommend testosterone for hypoactive sexual desire disorder, which is what most of us use it for, but we know that there's other benefits. But hypoactive sexual desire or low desire, I want to have sex, but I can't. Like, it's frustrating me. I wish I was having sex, and I'm not. So we use Testim. We have to use a male version. We have to titrate it to 1/10 of what a man uses. And so that's what I usually use for my patients, or sometimes still do the government approved.
But just to be clear, because it's a little bit confusing, what you've been talking about, of course, is using systemic testosterone in order to help with primarily low libido and some of these other things, which is different than what you'd mentioned before, is waking up those testosterone receptors in the vestibule, vulva, and vagina. And for that, we have to go to a compounded product because there is no FDA-approved product. And we do use that particularly in the lower part of the vagina and the vestibule. But one word of caution, a lot of women think, well, I'm just going to put some of that on my clitoris. Don't do that, because it will make your clitoris bigger. A bigger clitoris is not a better clitoris. It is not a more sensitive clitoris. Might I point out that penises are just great big clitorises, and they are way less sensitive. We have tenfold the number of nerve endings per, millimeter. So you have to know where to put it and what your goal is. Libido versus lubrication.
A lot of visuals for us today, Dr. Streicher. Okay.
I'm sorry, I didn't hear you.
Test testosterone levels when you start using it?
For systemic, we do. And it's not, we talk so often about how it's really not that helpful to test estrogen, and we don't test estrogen, everything that you've already heard. Testosterone is a little different, and we do test it because, number one, we want to know where someone's starting, because even if they're postmenopause, their adrenal glands are still producing. And if someone has a physiologic, normal amount of testosterone, we don't want them shaving. We don't want them getting acne, and it's not going to help them. That's the pellet problem that Dr. Larkin also already talked about. So we do follow those levels and a few other little hormone levels too to predict if you're going to get a good result.
Female normals the same as male normals?
No. 1/10. Women make 1/10. That's what Dr. Rahman was just talking about. 1/10 the amount.
And I think we have.
And we're going to hold the
We're gonna
question
do
now.
questions
So we
right
can,
at the end. That's okay. So DHEA, we really kind of hit on that already, right? Do you want to just briefly give us a one line on that?
DHA is precursor to both estrogen and testosterone in the cells. When it gets into the vagina, they come in suppository forms. The FDA-approved version does. And when you put it in the vagina, it converts into estrogen and testosterone into those cells. Studies have shown it dribbles down into the vestibule, so you get a 2-for-1 in that respect. It just takes a little bit longer to get there. Okay. But yeah, very helpful.
Thank you. Stephanie, a lot of women still have pain even upon using vaginal estrogen and or DHEA. What do you recommend at that point, and the reason there could still be pain?
Thank you. Well, one of the reasons I'm here is because pelvic floor muscles can cause pain. But one of the first things that we're catching in the clinic, if patients are referred to us by a gynecologist who maybe gave them vaginal estrogen, the same things that Dr. Streicher and Rahman talked about, they may be putting it in their vagina and not on their vestibule. And they may not be going back to that doctor for another year because they had their pap smear. But now I think my vaginal estrogen isn't working because I still have painful sex, irritated bladder symptoms, and I don't feel good. So it's important to know from why PTs have to know so much about the medical side is because we're going to see them every week to treat the painful muscles that they have and some of the disorganization in their body. But half of what we're able to do is explain you don't use vaginal estrogen for 2 weeks and expect that that's going to work, especially if you were symptomatic GSM before getting the medications that they talked about. So I think one of our very important roles as physical therapists is to be supportive and make sure they know how to put the topicals around their urethra, because a lot of people here put it externally and they're putting it on their leg and their labia. To us medical professionals, externally means distal to a hymen. To a patient, it may mean the labia. And so that's just something that I see over and over again that's easily remedied, but then we need some reassurance that this is going to take a little longer than initially thought. In pelvic floor physical therapy, we are examining the ribs, the muscles, the connective tissue, and the nerves from the ribs down. So this doesn't include just a transvaginal pelvic floor exam, but also making sure the pelvic floor muscles are coordinating with the rest of their core and their breath, which tends to get it interrupted as early in many women as childbirth. So in many other countries with socialized medicine, women are required to do postpartum physical therapy, and this is the first opportunity that women are really set up to have a pelvic floor disorder that may not be bothersome for enough into their life until they get into menopause and all these other things start happening too. So at that point, we really have to examine not just a Kegel, not strength and endurance, but is there pain? And if there's pain, we use manual therapy techniques to reduce the pain before we try to do things to increase muscle tone, which could make a painful muscle more sore. There's also various neuropathic issues that can occur in the pelvis, in the genitofemoral, ilioinguinal, and especially the pudendal nerve, which innervates everything. So there's often injuries to the pudendal nerve during pelvic organ prolapse repair surgeries. It could have started after postpartum, or there can be some mechanical causes. Because we also talked about the clitoris and the pudendal nerve goes there, I want to also discuss female vulvar hygiene. So as we age, the size of the clitoris starts to shrink. With that happening, the hood of the clitoris can start to stick to the clitoris itself. If we get discharged smegma, if there was a cleared vaginal fungal infection but still some issues with the skin, this can lead to the clitoral hood fusing on top of the clitoris. And we can easily prevent that by retracting the clitoral hood in the shower every time we wash, just to make sure we're getting water under there and no adhesions are forming, or these things that are being called keratin pearls. I can never look at that piece of jewelry again, now that this is a prolific thing.
You don't want those kind of pearls.
Nope, don't want those pearls. But so many people develop this clitoral pain and are coming to physical therapy when really it's a local pathology and not even referred from the muscles or the pudendal nerve, as I mentioned. So one of the supportive roles we can play as physical therapists is in the differential diagnosis. Is there a local pathology? Is there a hormone deficiency that we can see visually? Do we think there's an infection that hasn't really been cleared by the standard gynecologist? Or is it our muscles that are causing that? Because these muscles and tissues, again, cause all the same symptoms except for the libido issue that I just mentioned. Now, in addition to the diminished orgasm that we started to talk about, the hormone changes and supplementation are really going to help get everything to come back. But if there's pelvic floor muscle weakness or pelvic floor dyssynergia, your ability to have a rapid, pleasurable muscle contraction orgasm is going to be different. So that's one of the side benefits that we can provide. Many people aren't coming to us because their orgasms are diminished. They have all these other symptoms, but a side benefit may be that all of a sudden that's coming back stronger, faster, or harder, and no one is complaining about that.
Right. How many sessions approximately?
So this varies, the amount of sessions. If people are just coming in for a checkup because you've heard this lecture, we're going to identify the impairments and have short-term goals to reduce those, and then longer-term goals that are going to be your functional symptom outcomes. You don't want to leak, you don't want to have irritated bladder symptoms, you want sex to be pleasurable. The impairment-based goals can take 4 to 12 weeks, roughly. If I'm seeing somebody who has all of this and a severe pelvic pain condition, sometimes that can take longer, and the appointments are usually weekly for 1 hour.
Okay.
And by the way, no soap on the clitoris. Just water.
Just water on the clitoris.
I want to be clear, because hygiene's
Yes, I said
important,
water.
but no soap.
No soap.
No products, no feminine hygiene
But
stuff.
everyone can retract their clitoral hood and see,
Right, right,
and that will also help with orgasm function. If it's starting to phimose without pain, you're going to have hyposensitivity of the clitoris.
All right, number 5. Good. Dr. Streicher's on the edge of her chair here. Talk to me about this.
One of my favorite topics. We're talking vibrators.
Yes, we are.
So, I could do this one all day, but I'll keep it short, right? You know, we always think of a vibrator as being a toy, and it is. Toys are something to have more fun, but I refer to a vibrator as a tool, because a toy is to make something pleasurable, a tool is to make it possible. And what we now know, I mentioned that over 50% of women post-menopause are not able to have orgasms because of the decrease in blood flow, because of the changes that occur, but also because of changes in nerve endings. Particularly, this can happen in any woman as a consequence of menopause and aging, but when we look at certain medical conditions like diabetes and vascular disease, you can have nerve endings that are no longer responsive. You've all heard of foot neuropathy. With diabetics, you can have a clitoral neuropathy, and most endocrinologists are not chatting about that at your appointment. So this is the deal, and this is the short answer to a very interesting topic, is you have different kind of nerve endings in the clitoris. Some respond to soft touch, some respond to pressure, some to respond to vibration. The nerve endings, and you know where I'm going with this, the nerve endings that respond to vibration are bigger, and they have a protective myelin sheath. So what that means is as you age, all the things that were your tried and true methods to have an orgasm when you were 30 or 40, if suddenly they're not working anymore, it's because those nerve endings are out of business. They've had it. But thank the Lord, the nerve endings that respond to vibration, they're going to keep on going. And that is why women will have an orgasm with a vibrator when nothing else is working. So if this is a tool, I tell medical students, don't ever say to a patient, do you have a vibrator when you're taking a history? What you say is, when you use your vibrator, because we have to normalize it.
Well, and that goes to my next question, Dr. Rahman, because how do you communicate that with your partners? If you have a partner that, and you don't want them to feel, is it me? What's going on? How do you communicate a change of need?
Yeah, I mean, I think it's important. Communication is like the essence of really having a pleasurable sex life. So I feel like if you can't talk to them, it's not a me problem, it's really a we problem, right? Like we both have to work on, you might have erectile dysfunction if you're having sex with a man, or, or Peyronie's disease or whatever. And so just like you would want him to communicate with you, if you're heterosexual, you want him to communicate with you, you'd want the same, he would want the same. And most men really want to pleasure their partner. Most partners want that pleasure for their partners. And so I think it's just having them understand. That's why I think when people listen to our podcast or go on social media, it's a lot of them are men that are listening, or partners of people that are there listening to the information that we're giving, because it's so important for them to hear, okay, it's not actually just that she's not interested in me anymore. It's not that she's, unless it's a true problem with your husband or spouse or whoever it is. I think the communication is of the essence, to understand that these are processes that are happening because of a hormone deficiency, and we're trying to work on them, but I do need to augment this. And it's not about you, it's about us.
Okay, I want to get to Q&A because I'm assuming you guys have a lot of questions, but I want to ask this one question. Oh, sorry, I lost my place totally. Oh, over-the-counter moisturizer and lubes. Let's hit on that real fast.
Just
to treat
quickly.
GSM.
Yeah, the moisturizers are great. They're like, you're supposed to use them like twice a week. Just when you think, my patients always say that their vagina is so high maintenance now, but it's true. Like, you have to do a lot to really get it to a point where you can actually enjoy sex and diminish urinary symptoms and all of that. So hyaluronic acid based moisturizers are something great to use about twice a week. Just like you moisturize your face, you want to moisturize your vagina. And then lubricants, whether they're water based, silicone based, whatever you're using from your house, are very important as well. Some people might be irritated by them. I think most patients really like the silicone-based ones because they're really, they last longer, more slippery and all that stuff, which are really important.
Perfect. All right. Let's get questions. If you guys want to put your hands up, we'll get the mic over to you right away. Sorry. Okay.
And am I open? Yeah, there we go.
Hi, thanks so much for being here. I'm a fitness professional that works with pelvic floor therapists, and so I reintroduce women back into fitness after pelvic floor therapy, whether they're there for prenatal, postnatal, or menopausal care. So thank you for being here. Ladies, get to know your pelvic floor. It's really, really important. And the other comment is that we should normalize toys and tools and whatever else. I had gone into my care provider, who really blew off not being able to achieve an orgasm. And my husband, who's here today, he's a physician, but he went online. He's like, pick out 50 toys, we'll buy them, we'll figure it out. So it's really important to just have a good partner and to be honest and open.
Can I just add something super quick with that, because we haven't talked about it? Sex therapy.
Oh,
We've not, and of course Dr. Hagesburg, but I cannot emphasize enough for couples who love each other, they have a great relationship, everything is fine, but their relationship, their sex life has been sabotaged by everything we've been talking about. We can fix the tissue, we can fix the muscles, but sex therapy is so important from someone who knows what they're doing.
Biopsychosocial is really important for these sexual medicine concerns. So that's why, we can do the biology, but we need someone else to use the other stuff.
Thank you.
Have fun. We have a question here.
Okay.
Hi. Dr. Streicher, when you said that you can't think of any situation where vaginal estrogen couldn't be used, what about bladder cancer?
There's not a lot of data. Let me just start with that. But there's no data the absence of data is not the same as data. Let's put it that way. But I'm not aware of any reason to not use it with bladder cancer. Is anyone else, any other panelists? Yeah, I'm not aware of any data that says it's a problem.
And one quick question on red light therapy devices for vaginal health, yay or nay?
For what kind of devices?
Red light therapy.
I have seen no data, so I would not give that a thumbs up.
Okay.
We're all very data-driven here, you know? Show us the data.
Dr. Streicher, you forgot to mention osmolality and lubricants. Stop buying cheap lubes. Make sure that you turn.
All right, I'll give you the quick this. When we talk about lubricants, number one, what you need to realize is that lubricants do not change the tissue. They just grease the skids. They make it more slippery. But you don't want to use a lube that's going to irritate the vaginal walls. And what we now know is not silicone. We're all lovers of silicone lubes. Those are great. But the water-based lubes, particularly the ones that are the number one thing on the shelf, that are the cheapest, that start with some letters, you know, okay? The osmolality is sky high, and we have data that shows it actually eats away at the vaginal tissue, eats away at it. So you want a low osmolality lubricant, and people always, you know, I have a list in my podcasts and books and all of that, but the way to know is if they don't tell you what it is, it's real high. It's real high. The people that have low osmolality are going to brag about it.
I've had breast cancer, so I'd like to know if vaginal estrogen works in the same way for women who are suppressing their ovaries and actively taking aromatase inhibitors.
The answer is, as far as we know, yes, but not a lot of data, specifically in aromatase inhibitors.
But
Great
that is
question.
a tough one. Aromatase inhibitors, like that really destroys, I think, the vulvovaginal area in general. So it's really, really hard to get good treatment.
And the other issue, of course, is women who've had radiation.
Yes.
So many women who've had radiation to the pelvis for anal cancer, rectal cancer, cervical cancers. There's a lot of cancers that you end up with radiation. Radiation is not good to the tissues. So, but it's all, you know, we can still do stuff. The one caveat I will say is the sooner you start, the better. You know, I talked about how you can fix this stuff years later, radiation. You want to get on board with this really fast.
Thank you so much. This has been fantastic. I do have a question regarding if the majority of your symptoms are vaginal, would you also suggest doing the estrogen patch and progesterone or just vaginal cream?
It's two different, you know, with shared decision making, we hear this term a lot, it's what is your goal? What is your goal? So it's not one or the other. It's not both for everybody. It's what are your goals, and then you get your, what I call your menopause master plan. You know, how you're going to figure it all out. But you can use them both together. That's the most important thing.
Hi, my question is regarding the DHEA cream. Can it just be purchased over the counter, or do you need a prescription
DHEA is a
for it?
prescription, so it's an FDA-approved product. It's prosterone, and the trade name is Intrarosa, and it's a suppository actually that you use nightly. And so, unfortunately, insurances make it very difficult to get it covered many times, but it is by prescription.
And you can get a compounded version that is a cream, but you still need a prescription.
Yeah.
We have one on this side.
Hi, I'm 43 and not experiencing any of this, and this was very scary, I just wanted to say. But so I'm wondering, is there a role? It sounded like when you were talking about pelvic floor or the vaginal estrogen, of using it before you have any symptoms? Like, when should you start?
For pelvic floor PT, I think everybody should have an evaluation after birth and as they enter perimenopause and menopause, because if there is dysfunction, it may not be symptomatic yet. And so it's quickly fixable, just like if you have an ankle sprain or a knee sprain. So I do think it should be standard of care, and hopefully it will be soon. Was there hormone questions with that too that you wanted to?
Oh, yeah, in perimenopause, I often will, go ahead and prescribe vaginal estrogen or DHEA, because, perimenopause, again, with these big hormone fluctuations, like when you feel like there's a lot of estrogen, you might not feel it, but there might be times or months where your levels are on the lower side and you do feel a little irritation or pain with sex or difficulty. And so, this is a chronic progressive condition. If you don't treat it, it may not bother you now, but for most patients, at some point it will. So I like to get ahead of the eight ball and try to get them going with that.
So my question, I'm so thankful for all of this, for all of us sort of middle life women. I'm just weeping here for my mom and my aunt. And fortunately, they're healthy, but learning about the cardiac benefits of estrogen and the bone benefits and the reducing UTI, all of that. I mean, is it appropriate to suggest that they're 80 and 77, basically healthy, that they speak to their doctor? Is there a hormone replacement that you don't start until you're 75? I mean, what is?
So the local vaginal stuff, honestly, you can start anytime if she's symptomatic. Not everybody is. When you're talking systemic, and I think the hormone panel really addressed that, it's really very individual, and you have to know what someone's cardiac status is, but it's not off the table. There was a very, very good study that just came out with 10 million women who were taking hormone therapy over the age of 60 who did very well. But taking it through your 60s, continuing it, is different than starting it. Totally different, and that is a very individual thing. I actually have a podcast episode specifically about starting after 65, which is like from 3 weeks ago with Dr. Jim Simon, a colleague of ours who we all adore, that really talks about how do you evaluate someone and when is it okay.
Any other questions?
I think we have some over here.
Hi, just want to thank you all so much for all of this. I'm from Lexington, Kentucky, and I'm a provider at a very large women's health center. The number one complaint that women have when they come in is they'll start head to toe, hot flashes, night sweats, sleep. I mean, they hit all the way down. But then they'll start weeping when it comes to intimacy. They no longer have any sex drive. Sex is painful, and it's so sad when they say, my husband's going to leave me because I no longer desire sex. I mean, it's just, you sit there and you listen to them, and it just breaks their heart, breaks my heart. So testosterone, that's one of the things I want to touch on, where it's not FDA approved for us. We can use compound facilities. We can do the testosterone creams. But what do you do for the patients that their testosterone levels are not rising? Because, there's that absorption. We work very closely with a compound pharmacy. So we know our pharmacists, and they'll come in and they'll talk to our providers. And they'll change around the carrier of the cream. With you using the gel, you said again that you do the 5. Do you just do the gel for 10 days, or how are you?
Oh, no. This is every day. But I also want to mention that when you look at how well testosterone works in postmenopause women, you're looking at best a 50% improvement rate. And that speaks to the fact that libido is so multifactorial. And we haven't even touched on all of the reasons that can impact on libido. So the critical thing, and I know you keep hearing this all day long, but you have to see an expert, someone who really knows this stuff. And unfortunately, most gynecologists, most primary care doctors have not been trained. But there are many, many things that can be done to help with that situation, but I don't want people to walk out of here thinking that testosterone is the be-all and the end-all.
One of the things is we have pelvic floor physical therapists that we absolutely love. They're amazing, and what you all do is amazing. It's great.
I call them my magicians.
Most of the women that go, they're like, oh my gosh, I love this.
Yeah.
And so does my husband. So it's great for that. So it's a combination of everything. But when you're using pelvic floor, insurance won't pay for Interosa. We're so limited on what we can do for patients. That's what I was wondering if it was a 10-day, how are you doing that? Because mostly we just do the compounded testosterone creams.
So
Yeah.
it's not a 10. I meant saying that one tube lasts 10 days, but if
Okay.
you have 30 tubes, it'll last you 300 days. So you really just need to give them 1 month supply. It'll last them almost a year. But if at 6 months they're not really having a change in their libido or sexual function, then they can discontinue it. And you have to bring in sex therapy. We can use off-label use of some of the premenopausal medications that have been tested in postmenopause that will increase your dopamine or norepinephrine, the injectables, or the pill. And so those we can use off-label. Just for the providers in the room who are interested in learning more about sexual function, we do have an organization, the International Society for the Study of Women's Sexual Health, ISWISH, and we have fall courses, and we teach other clinicians how to treat sexual pain and sexual dysfunction.
But one last thing that has not come up today that I think is important to mention when we talk about sexual function is how often do women go to their doctors who are 50, 60 years old, they say sex hurts, and maybe if they're lucky, they're given a prescription for local vaginal estrogen, and then it doesn't work. So they think, okay, well, it's not working. It's not working because in most cases that woman was never examined. These things are being prescribed without an exam. She might have an entirely different condition. I have seen vulvar cancers, lichen sclerosis, pelvic floor issues. We all have a long list. So please, if you can start with a local vaginal estrogen, if it's not working, you need to be examined by someone who knows what they're doing.
And that is a good point. There are so many inflammatory vulvar skin conditions that really, increase. We see it, we see more symptoms, at least, in pre-menarche and post-menopause because of the estrogen deficiencies. So we really need to be cognizant of the vulvar architecture, too.
Okay. A question over there.
Hi, this is loud, sorry. Hi, I'm a pelvic floor therapist, so the whole day has been amazing. But my question is, as a pelvic floor therapist, I spend a lot of time educating women on what their options are, right? And in our area, we don't have access to great providers. Last night, I had a 30-minute discussion with a local provider who basically mansplained hormones to me and told me that my patient who's having night sweats is estrogen dominant and needs to say no more. As a pelvic health provider, how do I talk to doctors in my area and respectfully, because I really wanted to tell him a lot of things that I—
It's hopeless. You don't. Don't waste your time.
What do I
I'm
do?
sorry. It's a waste of time. You know, if you had something really seriously wrong with a family member, with a kid, you would find an expert. You don't try and explain it to the expert that happens to be the so-called expert. So yes, you go to the Menopause Society website, you put in your zip code, you can find someone who has an interest. Full disclosure, I work with MIDI that has clinicians that you can do by telehealth all over the country that specialize in menopause. You can find an expert, but you really want to think you're going to get anywhere mansplaining, this guy who's mansplaining to you? I don't think so.
Right?
But I want to touch on that because that goes back to the point that someone asked about sending in their mother and grandmother. Like the panel that you heard here today would be giving anybody very different experience than the person that's mansplaining to you. And it almost can undermine us as physical therapists because then they're acting like I'm uninformed. So I'll start out by sending them to Dr. Mary Claire's Instagram or other Instagrams and the societies if they're not going to bother to read the North American Menopause Society. And if that doesn't work, we're finding another doctor. And I can give them my 7 pages of credentials to explain why I'm able to talk about this. And that's it. Thank you to these people because that's why.
All right. Well, thank you all very much. Thank you.